Cast is now starting. All attendees are in listen-only mode.
Are we good to start?
Mm-hmm.
Okay. Good morning, everyone. I'm Mary Joseph from the Primary Care Coalition. I am a co-chair with the Maryland Colorectal Cancer Task Force, and we welcome you to this webinar this morning. It's going to be recorded and will later be recorded or posted on the Maryland Department of Health website. So your lines are going to be muted toward the day, and you can send questions in the chat features, and a post-event survey is going to be available to you. And remember, don't share any personal information. So please, if you have a client or a patient that has something that you want to share, don't tell their name or something like that. And so we want to go there. So I want to tell you a little bit about the Maryland CRC Task Force. It's state-based, volunteer. It's led by an effort to reduce colorectal cancer's incidence and mortality. This has burdened the state by achieving the best, by 8%, of colorectal screening in the state. Overall, the CRC screening rate, disparities, and goals. So the Maryland CRC screening rates, disparities, and goals. So Maryland overall colorectal screening rate remains just about 70%, but we are still trying to capture many communities that are lower. These are mostly rural communities, and there are certain communities that have certain racial or ethnic communities that are underserved in this figures. So as a result, with COVID virus, with screening rates being low because of COVID virus, they have decreased, and we want to make sure that these people are screened. So as a team of medical professionals and educators and influencers, we must continue to keep working through this epidemic to bring down these rates. And so that we are really making sure that everyone is screened, everyone needs to be, who is screened, everyone who needs to be screened is screened, and that we make sure that they understand why screening is important. So I'm going to start out with our guest speakers today. And our first guest speaker is Dr. Kevin Shindell. And he runs the inpatient practice at Franklin Square Hospital and an outpatient practice. He also serves as the medical advisor for the Pcmh program for Care First and the medical director for the Celtic Hair Care in Baltimore, and is a member of the credentialing committee for Care First. So Dr. Shindell, please start. Thank you.
Hi, thank you for asking me to speak today. My name is Kevin Shindell. I'm an internist. I practice in Northeast Baltimore. To correct it, I'm not doing any more inpatient work. I teach at Maryland, clinical associate professor in internal medicine in the Division of General Medicine. I run purely an outpatient practice at this point. With COVID, things have changed a lot, and the hospitalists are pretty much running the inpatient services now. I also serve as the senior medical advisor for the Care First Pcmh program. We've been around for 11 years. Program highly focused on the patient care, cost, and quality. Today, my talk is going to sort of center around 5 topics. We're going to review, just because I'm the first speaker, a little bit about literacy and healthcare literacy, sort of how it's changed over the years. We're then going to review the American Cancer Society guidelines for colorectal cancer. And then we're going to try to intersect healthcare literacy with the guidelines, specifically looking at best practices that our medical advisors in the Care First PCMH program have developed for folks in order to increase the screening process. Our goal is like yours. We want to try to beat that 80% mark. We're going to also talk, and I thought I had to say something about COVID. COVID has affected colorectal cancer screening. So we're going to we have a brief study from 2021 that actually looked at that. And then last, I'm going to show you some data about what our program's doing and how we're trying to make it better. So we'll look at our next slide. Just to start with the definition, we'll get it. Very good. Literacy is really defined as the ability to use printed and written information to function in society, to get one's goals, and to develop a better knowledge potential. That's general literacy. Literacy has a lot of components. There's the oral literacy component, which is listening and speaking skills. There's printed literacy, which is what we read and writing. There's numeracy. We'll talk a little bit about that, specifically with ability to work with numbers. And cultural knowledge has a lot to intersect with all these together. Literacy and healthcare literacy are a little different. And the U.S. Department of Health and Human Services have really focused upon the fact that when you talk about healthcare literacy, you really have to think about all of those components: oral, printed, numeracy, and of course, cultural knowledge becomes even a more important piece when we look at the social determinants of health that we're all focused upon differently that we didn't think about years ago. I think my first big point I want everybody to take home is research shows that limited healthcare literacy skills are associated with worsening health outcomes. This is the theme of today's talk today, meaning when patients' literacy is better, their outcomes are better. When you look what happened in 2010, 2011, the American Community Survey looked at the general population, about 295 million Americans. What they found was that about 60 million, or 21% of them, spoke in a language other than English at home. So individual skills to sort of deal with literacy, specifically healthcare literacy, was somewhat of the focus in 2010. As we moved along into 2020, really the focus was on the patient experience with providers. The healthcare survey really looked at the fact that about a third of the people who are age 12 and over reported they were not fluent in English. And this clearly, had a big impact on English proficiency, as well as the assessment of barriers to getting better health and the best healthcare services we could serve. You all may have heard of the CAP survey, which sort of evolved in the 2020 group. More of an emphasis. CAPS is part of our Care First PCMH quality scorecard, where doctors are assessed by the patient on their experience. So we're not only saying, hey, it's all about the patient figuring out how to access things, but the systems and the healthcare providers figuring out ways to improve care. 2030, the Healthcare 2030 Healthy People Project really organized the social determinants of healthcare into 5 domains: economic, educational access, healthcare access and quality, neighborhood and built environment, and social and community context, which sort of gel together all of the key components of people's experiences and how they live and how much that intersects into them being healthy. Healthy 2030 really addresses both the personal healthcare literacy and the organizational healthcare literacy. So look at our next slide. 2030 definitions really looked at the fact that personal healthcare literacy is the degree at which individuals have the ability to find, understand, and use information and services to make good healthcare decisions. We're hoping to intersect that with the organizational healthcare literacy, and Care First is an organization, really is the degree that organizations equally enable all individuals to find, understand, use the information and services to get informed, good healthcare decisions, and also to basically have access to healthcare in an equal way. So I think what's changed and what we're moving in the direction of, and particularly with the Healthy People 2030 project, is the intersect of personal healthcare literacy and organizational healthcare literacy. We'll look at our next slide. This just presents a little bit of data from the program for the International Assessment of Adult Competencies, which was presented. And what it showed was that, you know, there were three sort of specific competencies they looked at. Literacy, ability, of course, to do written and written text specifically and speaking text. Numeracy, ability to understand numbers, mathematical and content sort of additional skills, and then problem solving. And what this data kind of showed, it was interesting. They looked at people 16 to 65. And when you look at 6 levels of proficiency, for Americans, 18% for literacy were below level 1, or at level 1 or below. There were 6 levels, 5 being completely the highest, 1 or less than 1 being the lowest. So 16% were actually at or below level 1. That's as far as literacy proficiency. How does this compare to other sort of countries in the world? Japan was 7%. So big difference. When you look at numeracy, ability to understand problems and mathematical computations, etc., 28% of Americans were at level 1 or less. How does that compare to another a sophisticated society such as ours? They looked at Japan, 8%. So we were 28%, they were at 8%. Big discrepancy in what folks really, when you look at specific proficiencies, are doing when you compare two very sophisticated, highly technological societies in the free world. So let's look at our next slide. What are the attributes that an organization can do in order to really help promote the organizational literacy, specifically that when we think about an organization such as Care First? Clearly, leadership has to promote it, from the CEO all the way down. If it doesn't start at the top and follow all the way through, making it a priority, it is going to fail. 2, you want to have an evaluation process where you're looking at specific parameters and it's being evaluated on an annual or a semi-annual basis to make sure that folks are really, you know, the message is getting through. You need to include the consumers. That's our members. That's the people we serve. The folks that are paying the premiums and need to have the access to get the care that the good care that they need. Obviously, we can't leave anybody out. Everybody's got to be a part of this. We also have to ensure that the access is easy. You can't make when you've got a bunch of barriers, that's a problem. You want to design materials that everyone can use, no matter what literacy level you're working from. Obviously, last but not least, we want to target the high-risk folks, and we do that in the Pcmh program. We really focus upon the folks that have barriers, such as healthcare literacy. We'll look at our next slide. We're now going to move into a little different modality. I'm looking at the American Cancer Society recommendations for colorectal cancer screening, and then we're going to intersect that healthcare literacy piece that we just talked about with what the recommendations are. Obviously, the newest recommendations are people over 45 need at least an annual fecal occult blood test or a multi-target single-stranded DNA test, such as Cologuard, a flexible SIG, a colon sigmoidoscopy, colonoscopy full, or a CT cholangiogram. Any of these, and these are the intervals that they're recommended, are considered acceptable standards for colorectal cancer screening. The gold standard is still colonoscopy, still the best, but these others are acceptable ways. The American Cancer Society has allowed us, and we'll talk about COVID, thank God they've allowed us to do this, have given us other ways to at least accomplish some screenings. We'll move to our next slide. Look at a little bit of data on how we're doing. And this is up through 2018. And what you can see here is that the trend in colorectal cancer screening for folks over 50 is improving. We have most of the members in our plan are in that 50 to 64 group. So a lot of these are in our group. You can see that the rates of screening are not at the 80% level, though, that the American Cancer Society would like us to be at. We'll look at our next slide. We're going to focus in on adults 45 and older by race. And you can see that the discrepancy pieces all of a sudden start to widen. Quickly is racial discrepancy. It specifically widens out when you look at the folks that are in that less than 45 age group. There's a big difference in the screening, colorectal cancer screening rates in these groups. We'll look at our next slide. When you look at insurance status, another challenge. Clearly, we know that economic and social determinants have big impact on why people don't get screened. When you look at the uninsured down on the far right-hand side, big difference, 30% prevalence compared to 65% prevalence in the private care insurances. Lots of reasons for that. And all the social determinants of health play into that. Rides, economics, access, unfortunately play a big piece in the goal of trying to get everybody the care they need. So we're now going to intersect what I promised you, sort of the thoughts about what healthcare literacy is, and some ideas on how maybe we can improve upon this. So we'll look at our next slide. What can docs do? And this homes on what I do. I saw 10 patients this morning, so thinking about these in your practice every day become important. First off, providers need to explain things, the importance of colorectal cancer screening in plain language. You've heard about this before on other talks that you've done on healthcare literacy, I know. But the importance of screening, also making it simple. This is not a hard process. Colorectal cancer screening, can be, and often is a simple process, and keeping it simple is key. Using visual aids is key. I have a Cologuard kit that I asked the company for. I actually whip it out when I talk about Cologuard with my patients. I personally did a Cologuard, so I can tell them I did it. So personal, feedback on what you did is often valuable to get folks to do these tests. And I think the teach back method is important. Review the directions with the patient. I tell patients simply, put it in the bathroom if you're going to do a Cologuard, for example, on arrival. That way it's right there. When you sit down, you'll think about it. Maybe not the first time, but perhaps the second to do your test. So keeping it simple, teaching it back, using plain language. The Cologuard directions are written actually in the 4th grade level. Agreed, we won't hit everybody with that. But I think if the doctor has the kits in the office, or if you're going to do fecal occult blood in the office, you can use that as an example. Many of the GI doctors have actually had the scopes on display. Use scope, and they can show the patient, this is kind of how we do this, so you understand what's going to happen. Basic directions we talked about. A lot of practices are using interpreters. I have a large Greek population because I practice near East Baltimore. In my practice, I don't speak Greek, but often they will bring an interpreter or a family member who is bilingual that can help bridge that gap and help explain things. And last but not least, follow-up. I can't overemphasize the follow-up piece. Doctors have to follow up. Patients don't always do things we tell them, and having gaps in your care is something we work around. We'll look at the next slide. These are best practices that our medical advisors in the Care First PCMH program developed. On our next slide. Thanks. Basically, really, and these are real-life ways that doctors can do a better job. Obviously, each patient, we try to hit this at the 45 age group for annual patients and new patients who have physicals. We offer folks fecal occult blood testing. That's the stool cards that patients can take home and test, or a fit test that's mailed to them to do. We have a portal at Care First where doctors can actually look up and say, oh gosh, Susie Smith didn't do her Cologuard this year, or Johnny didn't do his colonoscopy this year. We can then contact that patient and make sure they get that done. We can create a clinical compact where we actually partner up with a GI doctor. Most of the GI doctors are pretty good at contacting the patients when they're due for their next colonoscopy. But for the large number of patients who don't necessarily do the full colon, but do the other screening techniques, partnering up with a GI doctor. I have a partnership with the doctor in the suite next to me, and we kind of work together to kind of make sure our patients get this done. A lot of docs are assigning a medical assistant in their practice, sort of, I'm the MA in charge of colorectal screening, and that person kind of makes it their responsibility to make sure that they get these things done. And last but not least, Dr. Marshall down in DC uses this. He has daily or weekly huddles where the team at the beginning of the day says, let's go through everybody's charts, see who needs colorectal screening, and we're going to get it done. Telephone campaigns have been used where the docs have actually Called a patient and had a little recording go off if the patient needed colorectal screening. And last but not least, in our program, we have nurses. And our nurses actually help us get in contact of patients, particularly our sickest patients, and make sure those folks are getting those screenings done. We'll go to the next slide. I couldn't do this talk without talking about COVID. Unfortunately, COVID has affected every facet of what we do in medicine these days. And if you're a primary care doctor, you know, like me, we're losing our hair because of this. It's that craziness. You know, this comes from a study that actually was done by the American College of Surgeons. They looked at about 700 patients in 2020 and said, what's going on with the screening process? The first thing is that patients are screening less. Obviously, there's a lot of reasons for that, but we all know that unfortunately, all screenings are down. First, why is that? Well, there's a lot of barriers. People initially were very afraid to get colonoscopies or afraid to do tests or afraid to even come in my office and be seen because they were afraid they'd get COVID. Two, there's economic barriers. These tests cost money. Patients often lose their jobs, lose their insurance, and so what happens is those can fall through the cracks. And last but not least, we spend a lot of time talking about COVID in our practice. Every patient today, I talked about boosters. So as an example, the bottom line is when that happens, sometimes the screening stuff gets pushed down a little bit on the priority piece. But the interesting thing at this study, looking at 700 patients, was, you're right, total screenings came down. However, patients actually did better when they got home kits. So whether you did a Cologuard, which is a bigger kit, test kit, or a fecal called blood test, which is a small stool card you test. Pre-pandemic, the return rate was about a third. Only 32% of the patients returned it. Guess what? During COVID, almost 50% of the patients who got kits returned them. So the one thing we learned about colorectal cancer screening is, you know, even in a pandemic where things are tight, you can actually, the data came out that patients were willing to do these screenings at home when they were available. The other thing they said was that, you know, really patients don't get sick when they're getting the coming in to do the colonoscopy. The data really has shown that the incidence of getting COVID exposure in a screening test like a colonoscopy where special precautions are being done are extremely low. So for my last slide, and it looks like we're pretty on time, I'm going to show you a little bit of Pcmh data. This is what my program's doing. We started looking at colorectal screening and made it a quality measure in 2017. You can see that our rate was about 66%. And as you can see, even up through COVID, and in the first half of 19, we were banging it. I think if 19 had really not had COVID enter, we probably would have been close to that 75, 80% number. But unfortunately, COVID hit us and made a difference. And of course, 20, in the midst of heat of COVID, you can see we didn't do bad. We actually almost stayed the same, which compared nationally to colorectal cancer screening rates, depending upon the population and what data you look at, some people have shown 8, 10, 15% less patients got screened. We only lost 1% in the pandemic. So we're doing that data is good. The second piece is how do we compare nationally? Nationally, between 17 and 19, there was about a 1.4 increase in colorectal cancer screening. We actually went up by 2%. And I think 19 would have been even better if COVID hadn't hit on the scene, unfortunately. So the bottom line is that, you know, I think that the point of home kits being there and available, and patients surely be willing to do them in pandemics like COVID have shown out of the data. I think we've in our program showed that we're better, you know, we're actually doing better than the national averages on increasing. And actually we've done a lot better in not losing ground. And hopefully 2021, when folks are coming out and vaccines are available and patients are more comfortable with screening, et cetera, will show better data. What are we doing at CareFirst to mitigate this? We're really pushing docs. We've made this high on the quality scorecard when doctors are graded on their quality. Colorectal cancer screening is a quality measure at CareFirst. So we're encouraging docs strongly to get this accomplished. So in summary, I know we're getting near the bewitching hour. Hopefully we're able to review some thoughts about healthcare literacy and some definitions of what that means. And then we were actually going to look at a little bit about the current recommendations for colorectal cancer screening and how we've been doing. And then we looked at the intersect, some ideas on what docs can do, what organizations can do, and what best practices kind of are out there to try to get folks screened. We talked a minute about COVID, presented a brief data that I think is sort of impactful, and I wouldn't be doing a good job if we didn't throw COVID in the mix today. And last but not least, we looked at our own data and said, hey, we're not at the 80 percentile rate yet. We're working on it. We're a little better. We're doing better than the national average, depending upon what data you compare. And last but not least, hopefully our future at this will be better as we continue to put a lot of manpower and effort into this. So thank you for listening today.
Thank you so much for your excellent I'm sorry. I have a sinus infection, and I'm trying to deal with that. So your excellent presentation. So what we're going to do is now we're go to promising practices with Dr. Elizabeth Holtschuh, and she has been engaged in cancer treatment and prevention for over 20 years, professionally and as a caregiver. She has her master's degree in social service science, service manual, and I'm sorry, I'm just.
Mary, would you like me to take over?
Yes, please,
Okay.
I would.
Not a problem.
I'm sorry.
Elizabeth and Aaron, I'm sorry. If you could just do a brief introduction and we can get into the meat of this wonderful topic that you'd like to share with us. Thank you.
Yes, hello. Just very briefly, I'm Elizabeth Holtzclaw, and I'm in Kentucky with the American Cancer Society. And I've been working for ACS here in Kentucky for almost 8 years. And Aaron?
Yeah, I'm Dr. Aaron Cruz-Deer. I'm an assistant professor in the University of Kentucky College of Public Health and a member of the Markey Cancer Center Cancer Prevention and Control Group. And I've been working primarily in rural cancer prevention and control with folks on colorectal cancer for about 6 years now.
This was a perfect introduction to our talk because we just heard about at-home stool-based testing, and here in Kentucky, that's incredibly important if we're going to make that ambitious goal of ACS's 80% in every community. Next slide.
All right.
There you go.
Great. Yeah, so let's just talk a little bit about what Kentucky looks like in terms of colorectal cancer disparities right now. Obviously, when you think of colorectal cancer disparities, you think of that area in Eastern Kentucky, Appalachia in specific. Rebecca Siegel of the American Cancer Society published an article back in 2016 that showed 3 areas of the country that are, quote, hotspots where colorectal cancer mortality is clustered, and Appalachia is one of those 3. So there are a variety of factors that lead to that or that correlate with that, including lower income, higher unemployment and poverty, lower educational attainment, lower literacy. And literacy was really what kind of drove this approach here, in that a lot of times when patients receive instructions for these stool-based tests, they're a little bit difficult for them to read, and or often written with medical terminology that make it difficult. We also see that in Louisville and in some of the areas where the Black population tends to be clustered in Kentucky, there's a higher colon cancer incidence and mortality as well. And that's explained in part, about 50%, by lower screening rates among Black populations in Kentucky. So what we're looking to do is increase screening rates, and by doing that, we can reduce both new cases and deaths. But to do so, we need to make sure that our educational materials and our outreach is culturally relevant. Next slide, please. So again, this is the cluster. These are the hot spots that I was mentioning right there. So you can see Appalachia is one of them. The other is Mississippi Delta region, and then that area on the coast of Virginia and North Carolina. Next slide, please. So some patient level barriers to screening that we've found in our research, including this idea of fatalism, this idea of not wanting to know. So local culture, oftentimes, particularly in Appalachia, is if it ain't broke, don't fix it. And that's an actual quote that we received right there. So this idea of you only receive care when there's an acute condition going on, right? And as we know, colorectal cancer often doesn't, show symptoms until it's advanced. So that's a danger when it comes for colorectal cancer. Fear of those negative outcomes, competing medical priorities is extremely salient during COVID, where people have been holding back on receiving care, and by the time they go, they've got other things on their mind. And then financial concerns, education, knowledge, literacy, and travel and distance, especially in those rural areas. Next slide, please. And then at provider and clinic levels, there are barriers to promoting screening as well. So sometimes we see that physicians don't provide patients with all screening options. Sometimes they offer colonoscopy because they think it's the best. One of the negative consequences for years of calling colonoscopy the gold standard is that people have now think that other options are lesser options. So sometimes even in the provider's mind, they're only going to offer those stool-based tests to their average risk patients after they've said no to colonoscopy 2 or 3 times. And that can be a barrier to promoting screening. Educational materials, like I mentioned, are oftentimes generic and don't reflect local culture, needs, and values. And then time and workload concerns, especially again now in COVID, when patients are starting to come back, they need to rush through a lot of these visits and address many different conditions, and it becomes difficult to promote screening. Next slide, please. Elizabeth?
Yeah, so, go back, there we go. So here was the problem. We heard from the previous speaker about at-home stool-based tests. This is the simplified version for one kind of FIT test. And if you look at it, it's really not simple. Collect sample from stool before paper sinks. My favorite one is cover the grooved portion of the sample probe completely with the stool sample. That's not low literacy. I'm a social worker. I moved, as you can tell from my accent, I'm from New York. I moved to Kentucky, really getting to understand some of the challenges and opportunities we have here in Kentucky. And when I saw this, I went, boy, that's not gonna work. Aaron talked about Appalachia, and one of the priorities for us is Appalachian males. We also have in Eastern Kentucky, for one hospital, there was one GI doctor, and that entire hospital system at the time didn't even do FIT tests, so we had to work on that. We had very low FIT utilization rates and low FIT return rates. So the question was, and we had clinics that didn't want to hand out FIT tests because they just saw it as money out the door. So the question was, okay, well, are they not doing this because they don't understand how to complete the test? Next slide. So that is Mike, the picture of Mike. And here's the solution. If you've seen a talking Hallmark card or a singing Hallmark card that sings you happy birthday, whatever weird thing went in my head is I combined the two. The idea of simple directions and a local voice and a local cancer survivor. So we can hear that now, just a few seconds. Oh, I can't hear it. We tested this too. Let's try one more time. No, it didn't work. Oh no. And I am a technology.
We'll make
person
sure
who gets
it's
all
included in our post-session documents. Okay. Thank you.
So as you can see, this is the inside of the card. It has simplified language. It has the audio, so you open it up, you can listen to it however many times that you need to rehear the directions. The image on the card, Mike did not graduate the 4th grade. He worked in the horse racing industry at the tracks in Lexington. He sounds like he's from Lexington. He is from Lexington. And that was really important to me, that I didn't want a stock image. I didn't want a stock voice. I certainly cannot be the voice for Kentucky. And the size of the card matches the size of the fit test that patients were handed. So this is supposed to be accompanying the fit test that somebody would take home. So it's not replacing a provider having that education, but when they get home, they can listen to it over again. And hopefully have, one of the things that we hear is that somebody needs that personal connection to somebody who had colon cancer. Next slide. So you can see we've done some pilot work with this, a few different projects. This is our first project. So Mike went in the mail and we had some postcards that came back to see, did people like it? And they really liked Mike a lot. But then Aaron and I started partnering together because I desperately wanted to know, it seems like a nifty idea, but does it resonate? Is this what the community felt like they needed? And then, of course, how can we adapt this solution for other communities? Of course, eventually we want to do Spanish, and I would love to do a Cuban dialect in Spanish and a Mexican dialect in Spanish. Next slide. So Aaron and I have spent this year working on developing an African-American version of the talking card, and through some grants from the University of Kentucky, we were able to do focus groups with 6 Black churches. And for both of these cards, our goals are to address low literacy and low health literacy. It also addresses vision impairment. In Eastern Kentucky and Appalachia, we have a real problem with broadband. Folks don't have access to the internet. So all these fancy apps and websites, they don't work. We also have low tech literacy, especially for our older populations. And then really looking at health equity, not just health equity for Black and African American populations, but for those with poverty and low socioeconomic status in Eastern Kentucky. Next. So we've got lots of projects going on. This just demonstrates where Mike and all our other cards have been across the state, so we can really evaluate the efficacy of this and if it connects and resonates. Next. So this is a sneak peek of Reverend Freddie. We ended up doing 5 versions for the African American population here in Louisville. We didn't get clear direction on who they wanted the voice to be. So we did 2 medical professionals, a Black doctor and a male and a female nurse practitioner. And then I had 2 colon cancer survivors that were males, but one is Reverend Freddie, and then a female who you saw earlier, Miss Marie. So let's see, maybe this audio will work. You want to try it?
It's Claire. Yeah, let me see what we can do here.
All right.
No.
All right, well, we'll send it out. The great thing about Reverend Freddie is he sounds like he's from the pulpit. And when we did the focus groups to bring them back to the churches, first of all, Reverend Freddie got a round of applause. That was a delight. And other churches knew Reverend Freddie. So even the church that he wasn't a part of, because this was their community, they really connected with Reverend Freddie because this was their community member, their neighbor. He sounded like them. They knew him from social events. And he is telling his story as a colon cancer survivor to go out and get screened. So our future plans and lessons learned, that's what we always get. People want the card. Next slide.
Elizabeth, if I can just interject real quick and say one thing. I think one of the other real fascinating things that we found here, and maybe this is on the next slide, I don't know, is that our focus group participants in the Black churches, despite the script being 99% the same and recorded at the exact same speed, said by and large, we heard from multiple participants that they liked this version better because it was slower and clearer and easier to understand, despite the fact that it was the same speed, the same script. So just having a voice and a face that people know and recognize and that reflects them makes a big difference, and that they actually perceive tangible differences as opposed to just a level of understanding or a level of feeling. They actually see a difference in the card. So that's extremely important, and I think one of the critical points. Go ahead, Elizabeth. Sorry.
Yeah, no, Aaron and I get really excited. They also gave us feedback about that simple language. They loved the word poop. They loved that this card used language and a voice that they were familiar with and used to. They loved that we kind of stripped down the medical jargon and gave it in a way that they could connect with. So we're going to continue to ensure that the talking cards accurately represent the cultures and values of the audience that we're trying to work with. These focus groups have been remarkable, and the feedback has been fantastic. And it's opened the doors for other opportunities for Aaron and I to engage around not just colon cancer, but other health and screening and cancer screenings. We want others to share in this talking card momentum. But we are working on creating a core set of evaluation measures so we can continue to evaluate, is this working? How is it working? How are people using it? Because I know that people want to use a card like this in their own communities, and hopefully they can just plug it in. One question I always get, each card is only about $3, so it's not that terribly expensive. But we are still in that formative research phase so that when the cards are out in the wild, we know that they are the best quality. And we want to do a comprehensive multi-strategy intervention in both clinical and community settings. Next slide. Aaron, I think this one's you. The next one. Oh, no, this is me. And just while you are waiting for the talking card, just my little tips for you, really look at your patient education materials. Again, that FIT instruction that I showed at the beginning was supposed to be their simple version. People have sent me their simple versions with pictures, and I don't even understand what the directions mean. Do your instructions make sense? Do focus groups and ask your patients for feedback. Are they at a 4th grade reading level? Does the language reflect how your patients speak, like the word poop? But there's also been some really interesting dialect changes. The way people say the word envelope or toilet is different depending on where they live. Do your images reflect real people? That was feedback that we got from the focus groups. They could tell that we didn't just slap on a stock image. They could tell that these were their neighbors, their community members. Are you using a 3-step fit? That can be a barrier. It's hard for people to understand multiple samples. And do you have follow-up systems that include patient navigation and reminder recall? And is this part of the whole process? So again, this card is designed not to be an intervention on its own, but to be a whole structure that engages in communication and making sure that that patient really understands what you're asking them to do when they go home. Next.
And I think just to add real quick, I want to underscore that market research, because another thing that we found out in the original one in Eastern Kentucky, people would take their sample and put it in the mailbox and flip up their flag so that the postman would come and pick it up. When we went to Louisville, they said, we don't put anything in our mailbox for the postman to pick up. We find one of the blue mailboxes that's on the corner and we take it to there. So the whole idea of put it in your mailbox for your postman to pick up did not resonate to them. So again, this market research is really important so that you know what the people you're serving are actually doing, what their behaviors are, how they speak, what's common to their culture. So again, we're happy to take any questions that you might have.
Wonderful. Thank you both all presenters for your topics today. And we do actually have some questions. While I facilitate some of the questions, I'm also going to include our post-event survey in the chat box. But our first question comes to Dr. Shindell. What preferred health literacy tools pertaining to colorectal screenings have been most well received by both the clinical staff and patients to increase screening completion? For example, visual aids, audio, or the like. And was there a difference in terms of what was most resonated with clinical versus the patient population?
I mean, I think generally the idea of having, I do a lot of Cologuard in my practice because the sensitivity of that test is about 92%, which is almost as good as a colonoscopy, and I don't sell Cologuard. I think having that kit in there, and I have it actually in the box, sort of how the patient gets it, and I get the box out, and I lift the kit out, just like I did when I did mine, and take the top off, tell them, you know, how to do your business. I don't tell them how to do their business, but explain what happens. Put it in the toilet as soon as it comes, not the closet. As soon as you put it in that hall closet, it doesn't get done. And you know, you have to add a little fixative at the end. So I say, when you're finished, you put this in, you put the top off, goes in the same box. And and I show them where the number is because they do have to call for a UPS pickup. I think that's really helpful. I do have cards in my office, and I don't do a lot of fit, but I do for folks who really don't want to do the Cologuard, can't afford it. I'll do the fecal occult blood cards, and I have an envelope. I buy the kits, my practice does. And I actually have a kit out where I show them and explain that, you know, sort of how to acquire the sample. And I think seeing things universally makes a difference. You know, Cologuard actually has a process where they will mail automatically a patient a kit. And I think that doesn't work. The number of kits that they've been shown statistically returned by mass mailing outs of kits is so much different than when the doctor actually shows them the actual kit and does it. So I believe in visuals. I think it's a great opportunity. It takes literally 90 seconds to show some patient that. So for the doc that says, I don't have time to do that, no, that's not true. And if you don't have time, maybe your medical assistant could do it. Maybe your front desk person can even do it. I mean, everybody in my office is over 50. They've all done these tests. I think also the other part is the patient knowing that I did it. I've been practicing 30 years. My patients trust me. And most of my patients, I have a lot of families, a lot of multi-generational care that I do. I did one of these kits. So I think that very much helps. Just like living wills. When COVID came on, I did a living will because doctors were dying. I think patients knowing that their physician has done this is a very valuable piece. Now, am I reaching my whole community? No, but I'm reaching the community that I serve in my office.
Wonderful. Thank you. We have received some more questions. We do encourage attendees to continue to send in questions through the question queue or directly to me, Kathleen Connors-Juris, and I'll be happy to facilitate those questions for you. But for Erin and Elizabeth, with the audio cards being distributed with the Fit Kit, I know that you had mentioned in terms of the Postal Service and the ways that there's differences in the kits being mailed. Have you had any continued barriers in terms of the Postal Service, generally speaking, to any of the successes that you've seen as you've navigated this pilot in terms of delay, and have you had any workarounds in terms of how you have possibly addressed those issues?
Well, that pilot happened before COVID. So what would happen is somebody would do a community event or be at a health fair or at a doctor's office or something and doing the outreach themselves. They'd get somebody to consent to do a fit test that they were overdue and needed it. And then that whole kit was mailed. So as we just heard, you don't want to just blindly send somebody, oh, and we heard that in the focus group. They don't want to get these in the mail without knowing what it's about.
No.
So we didn't have issues getting the fits out. We do have issues with mail in Eastern Kentucky. We have big issues with Cologuard in Eastern Kentucky. UPS doesn't go to a lot of haulers in the mountains. So that is definitely a barrier that we have in our state, is getting those kits back in the mail. So some doctors' offices have actually asked for the kits to be returned just to their office, and then it's a whole thing. But in terms of the talking card, that's how it was done. So we had somebody doing that external conversation recruitment, and then the cards were sent as the follow-up.
And just to provide a little context to that as well, because I'm also part of I'm a co-investigator on an NCI grant that's doing a lot of colorectal cancer screening in Eastern Kentucky clinics. And they do a lot of Cologuard because they're very short-staffed clinics. They don't really have the ability to navigate through FIT. Cologuard tends to be a little bit easier with their resources at the time. But they do come into that issue where UPS, FedEx don't go into a lot of those communities. And actually what happens, because it was my former community that I lived in Southern Illinois, which was very rural, is what would happen is the post person USPS would pick it up, bring it to the post office, and then a day later, UPS would come and pick it up from the post office, and that can, of course, lead to problems with timing for the samples. So what some of our clinics did in COVID is they would actually put a drop box in their office and tell people to ring a bell or something like that when they drop something off, so that they could pick it up, and because UPS would make daily trips to those clinics. So again, it's all about creativity, I think, particularly during COVID with those mail issues.
Yeah, I mean, you had mentioned that during COVID, that they're not during COVID, but there's a paucity of GI doctors. I will tell you, I'm in Baltimore, pretty cosmopolitan area. GI doctors are swamped. COVID is really, remember everything. A lot of GI doctors closed their practices down for 18 months, and so all that, the tumble just went back. And I've had patients that had to, really had GI access, and that's where these other methods sometimes have to patch it through until the patient can get the GI access. And I think it's an important COVID point.
And Dr. Shindell, you're absolutely right, because we saw the same thing. We actually shut down elective procedures for a little over a month at the beginning of COVID, and that made an already backlog colonoscopy situation even more backlog, up to 6 months in certain areas. So a lot of these providers that were very, very reticent to promote stool-based testing started promoting stool-based testing as a primary because they had no other option, and they certainly didn't want their patients to get late-stage diagnoses. So I think that's an absolutely fantastic point, and I don't think it's a rural-only problem at all. It's everywhere.
All right. We have a few more questions before we close out the hour. But one of the questions was, I like your suggestion about using visual kits with patient, and this is not okay, and this is not often done. I noticed Cologuard has an instruction video on YouTube that I found it to be very helpful. Has anyone seen the video, and what are your thoughts on sharing instruction videos with your patients? I think we've addressed this in some way, but is there any conversation that you'd like to lend in terms of what you've seen from Cologuard and marrying that with your additional health literacy efforts?
I think the more the merrier. And, as our society is becoming very technologically based, people, nobody ever reads a book. They only look at things on the internet. The bottom line is, I think those are good. I've seen their video. It is, I think when you look from a health literacy standpoint, I'm not sure they're going to reach everybody. And maybe one kudo to them, and I don't know if your group could help, would be, hey, let's develop one that we think everybody's going to reach if they're going to choose this modality to get direction. They used to have a video. They used to have this. I'll show my old age. They used to have a disc you could put in. Well, nobody uses discs anymore. So they're trying to keep up with the times, and I think that's a smart a smart move. Anything, the more the merrier.
I completely agree with that. And I think, there's room for all of it. Absolutely, videos are great, but in some of those areas, especially in rural Kentucky, they may not have broadband access and able to look at videos. So having that simplified model that we can send out in the mail works in that aspect. But to your point, Dr. Shindell, about the video not necessarily reaching everyone, we did have one of our Eastern clinics in that NCI funded project I mentioned that created their own video with their own nurse and used actual Play-Doh to model the sample and show patients how to do the Cologuard. And again, it was in local dialect with somebody that recognized, and then they shared it on their Facebook page, which a lot of their patients subscribe to, which is different than going out to a website, because you can scroll through your Facebook and say, oh, that's interesting, what's this? So they found that to be a very useful media approach for them.
Cool. Very good.
All right, and I think we have time for one more question. And Elizabeth, you may have addressed this in terms of access and conversations into a more broad offering around the talking cards. I know that there's still some work taking place, but if one of our participants today, excuse me, would like to know more or ways to replicate that effort, what would be the best ways to, would it be to reach out to you directly or otherwise?
Yeah, I think that's fine. As I said, people see this and they get really excited and they want to do it. So that is part of what Erin and I are trying to think through, is how can we continue to collect good evaluation data, but also how is it that we can share this far and wide, because the response has been absolutely incredible. We had one guy on a focus group who said on the focus group, I had no idea that colon cancer screening was this easy. Tomorrow I'm going to call my doctor and ask to get it done. And I was just like, oh my God, that's amazing. So I think it also, having it in simple language, kind of tying it back into health literacy, helps people understand we're not asking, it's icky, but it's not complicated. It's not hard to do. And to keep that language and those steps simple helps people really see, oh, you know what, I really can do that. Even if they don't have lower health literacy, they may have been putting off because they were expecting something much more complex. So yes, it is our goal and hope to kind of come up with a system so that all of our friends can enjoy the journey that we've been on.
And I think the other part to mention is that this is really not a standalone intervention. It's a strategy that fits within a multi-component strategy. I mean, you can't rely on the talking card alone to increase colorectal cancer screening rates. It's just, unfortunately, it's a multifaceted issue that's going to require multiple components at different levels. Interventions that address provider barriers, patient barriers, clinic barriers, and sometimes community standards and values too. So it's one component of a multi-pronged approach that I think it addresses one particular area and one particular barrier to screening in this case.
So the goal would be Dr. Shindell sits down with his patient, he explains, he uses the toolkit, and then they go home and they take this, and this is a reminder. It's not the first time they've heard these instructions.
Sure.
The other thing that we heard in our focus groups, predominantly patients were never even given a choice. They weren't given an option. They had never heard of FIT. A couple of them knew the happy box from the commercial. They didn't connect that with colon cancer screening. So we as medical professionals also have to do a much better job having these conversations and engaging people in the decisions, because that really shocked me.
Sure.
And I know we're at the end, but just one real quick comment on that. We actually had one well-educated focus group participant say that she had a colonoscopy and had polyps removed. And when we mentioned that, polyps can turn into colorectal cancer, she said, "Are you kidding? I didn't know that. He removed polyps and never explained what the reasoning was for that." And again, that's part of the conversation. If people know that this is preventive, then they understand. Then they're educated, and they're in their own care. They can take control of that.
Repetition, 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 right? Well, I really appreciate your time today. This has been a wonderful conversation from all of our speakers. I also appreciate the time and attention from our attendees. As you'll see in the chat box, I've included some resources as well as our post-event survey. This is the third and final webinar in our health literacy series from your Maryland Colorectal Task Force. This is not where the conversation ends, so we hope that when you fill out your survey, you give us some suggestions and ideas of areas that you would like to hear more from us about. We also encourage you to join our task force. We are always looking for an array of systems, professions, and the like to be part of our conversation. And as you can see, we do not limit our conversation just to Maryland. Our friends in Kentucky have gifted us the time today as well. So with that, I hope everyone has a wonderful afternoon, and I thank you for your time today.
Thank you.
Thank you.